Assalamu alaikum. Thank you very much, and thank you for the organizers for organizing such a wonderful conference in Riyadh. So I guess one of the very commonest questions that we get in our clinics, perhaps the commonest, is, okay, I'm doing fine now. Can I stop my medication? Actually, maybe each one of you has a different answer to this question because we don't have solid guidelines, we don't have a solid evidence in the literature, and we're not very confident on what to answer the patient or what to do in these situations. So I'm going to go over the researches and over the registries and whatever evidence that we have in the literature to support whatever question we have to our patients. So I'll go through the literature, and I'm going to categorize the patients that should be in this drug-free remission. So before doing this, we need to define what's treat to target. So we all know that the patient has to be in remission before we decide to taper or to stop the medication. But what is remission? So I guess most of the guidelines agree that being in remission is having a DAS28 of less than 2.6, and having a low disease activity is having a DAS28 of less than 3.2. So what about the literature? What evidence do we have in the literature? So I'm going to go quickly over some of the studies, perhaps the strongest evidence that we have in the literature. For example, this is about infliximab, and it started, I think the whole topic started with infliximab because it was one of the earliest anti-TNF, one of the earliest biologic that we've had. And this is a small percentage of patients. The laser doesn't work on the screen, right? Okay, that's fine. So it doesn't work on the screen. That's fine, that's fine. So this is a small number of patients, just 20 patients. So after 12 months, after 1 year, they tapered down infliximab and they kept the patient just on methotrexate. And as a matter of fact, 70% of the patients sustained remission after stopping Remicade for 1 year. And this is another one, also on infliximab. So you know you're familiar with the BEST study. So what they did after 2 years of being in low disease activity, that's 44, that's 44 joints. So that's 44, if it's low disease activity, then they can stop the infliximab. And after 3 years, if a patient is in remission, a complete remission, then they can stop the methotrexate and keep the patients off medications. So what happened is that about half of the patient remained in remission. That's very interesting. And then half of the patient who relapsed, then they put them again on Remicade or on treatment, and the majority of the patients, they stayed in, or they could resume the medications without problems, and it was easy for them to go back into remission once the treatment was resumed. So 74% in a complete remission and 21% in low disease activity. Oh, the best marker for going into remission was having a seronegative patient, a patient who does not smoke, and if the treatment was going on for a longer period of time. And this is the retro study. So what they did, they took the antirheumatic treatment, whether they were conventional DMARDs or biologic medications, and then they categorized the patient into 3 categories, either continue DMARD or tapering DMARD or stopping DMARD. So what happened is that they found that most of the patients, I'm sorry, I cannot use the laser, but you can see that 51.9% of the patients flared up. Those are the patients who stopped the medications. The patient who tapered the medications, about 40% of them flared up, and then a small percentage for the patient who continued their medications. And again, the most important factor to determine whether the patient is going to stay in remission or will relapse is having a positive ACPA or a seropositive patient. And this one is the docera treatment that's on the docera study on etanercept. So, however, this is different because they did it on patients who were on low disease activity rather than in remission. And again, they put the patient into 3 groups. One of them continued the medications, one of them were on half the dose of etanercept, and one of them stopped the medications, and there was a difference between them. So the patient who did not stop their medications or taper down the medication did well. Again, the patients who were on half the dose did well, but the patients who stopped their medications did worse than them. And this is about biologics, whether etanercept or adalimumab. So the patients who spaced their medications did well, but not as well as the patient who continued their medications. Okay, this is the DRESS study, and actually I really like this study because it reflects what we do in practice. So what they did in this study, they tailored the treatment according to the patient. For example, if the patient flares up, then I can put him on steroid, I can put him on NSAID, if the patient is doing well, I can stop the medication, I can taper down the dose. So it's according to the patient, according to what we do in our daily practice. So the protocol of this study was completely different than the protocol of the other studies, and it resembled what we do in our practice. And actually what they showed in this study, that if you adjust the medications to the patient, then they do very well as if you continue the medications without stopping it. For example, if the patient is doing well, then you can stop the medication. If the patient relapses, then you can resume the medications, and then you can give him steroid on and off. And there was, okay. So, and there was a small evidence also on tocilizumab, and they showed that the majority, 84%, they relapsed after stopping tocilizumab. There was one, I'm not sure why it was not shown, but there was another one on abatacept, and about 50% of the patients on abatacept flared after stopping the medication. So how about the registries? Now, regarding the registries, I have to mention that going through the literature and going through our registry in Kuwait, because I tried to get some data from the registry in Kuwait, and I realized that it's really hard to get data from the registry regarding drug-free remission period. The reason for that is that our approach to our patients are different among the different rheumatologists. So some people will give steroids, some people will give NSAID, some people will stop the medication. So because our approaches are different, it's very difficult to group all the patients together and get a unified data for them. And it's really difficult to go on each patient separately because we have a huge number of patients. So the data about the registries is very, very limited in the literature. There was one by the Japanese people. And it's interesting that what they did here, 46% stopped their medications among the 1,000 patients. However, you have to realize that 41% of those patients were on steroid. So from my perspective, a patient who's on steroid, I cannot call this patient that he's on remission. It's very difficult to say he's in remission if he's on steroid. But that's what they did. So about half of the patients were on steroid. And they say that 67% of the patients relapsed, relapsed, and 78% relapse after 2 years. And then there is one registry, the Corona and the Ninja again from Japan. So about half or around half of the patients, they could continue on methotrexate alone or NSAID or corticosteroid. And this is a clinic in the leading early rheumatoid arthritis clinic. So also they showed that there is increased risk of relapse after stopping the medications. So who can achieve drug-free remission period? Can we select our patients? Actually, you should not unify this treatment or this approach for all the patients. You have to select the patients on which you decide to stop the medications for them or tailor down the medications. So of course, because of the invention of the new treatment like the biologics, it's becoming much easier than before to stop the medications. And patients who are, for example, seronegative, patients who do not smoke, patients in whom you started the treatment very early and whom you started an aggressive treatment for them, patients who are being on treatment for a long period of time and who have been in remission for a long period of time. So you select those patients and you try to taper down the medications and perhaps stop and see what can happen. And remember the risk factors for those patients. And actually, this point is important because you can decrease the side effects of medications and you can decrease the economic burden in your country. How about the guidelines? What do the guidelines say? And as Dr. Hani Al-Muallim said, we don't have a lot of thorough guidelines regarding the drug-free period. So in the EULAR, the EULAR people say if the patient is being in remission for a long period of time, then you may, and the patient should be off steroid, then you may try to taper down your medications. And the ACR people say if the patient is in low disease activity, then you continue your medications. But if the patient is in a complete remission, then you may try to taper down your medications. And actually, if you go through the guidelines, all of them agree that first you stop steroid, and then you taper down your medications. And, but however, most of them say that it's not a good idea to stop your medications, just taper down your medication. How about in Kuwait? So as I suggested that it was really difficult, and actually the statistician brought the data for me, and I refused to show them here because I thought they were not very accurate, and the message that we get from them, from the registry, is not that good because of the difficulty of the methodology. However, what I did, these are the people who work on the registry in Kuwait. So what I did something else. So I've chosen the consultants that we have in Kuwait, and I sent a WhatsApp message to the group, and I sent a questionnaire, a question. And I told them, please answer the question, but on privately, because to avoid bias. So every one of them sent me the answer, and the question was, if your RA patient is in a long-standing remission, what do you consider? So the first three questions about starting with methotrexate. So do you stop methotrexate and then you continue biologic, or stop biologic, or taper down biologic? Or you start with tapering down biologic and then you stop methotrexate, or continue on methotrexate, or you continue the same treatment. So what happened is that 13 people responded, and of course, Kuwait is not like Saudi Arabia. It's a small country. We don't have a lot of rheumatologists as the number that you have in Saudi Arabia. So 13 people responded, and you can see that most of them actually, they start with methotrexate. And that's completely different on what we have in the international guidelines. And that I completely agree with Dr. Hani Al-Muallim that we should have our own guidelines in the GCC countries because our population is different. The payers are different. The policies of the payers are different. So the international guidelines, they start with the biologic because of the cost issue. In Kuwait and perhaps in Saudi Arabia, most of the rheumatologists agree on starting tapering the conventional DMARDs rather than the biologic DMARDs, and then they go to the conventional DMARDs. Now, I try to group the answers together, and the majority, about 3/4 of the rheumatologists in Kuwait, they taper down the treatment, and about 1/4, they stop all the medications for the patients. And again, I grouped the answers in a different way. So 77% of the rheumatologists, they stop the methotrexate first, and 23%, they stop the biologics first. And these are the guidelines that we have in Kuwait, and it's in press, so you're going to see it in the literature after a very short time. And in our guidelines, we say if the patient is in remission for about a year, then you try to taper down either the biologics or the conventional DMARDs, and you should do this very carefully. And actually 9.27 agreed among that's the level of agreement. The score is from 10, so more than 9 out of 10 agreed on that protocol. So in summary, available clinical trials and real-life experience suggest tapering down rheumatoid arthritis treatment plus minus discontinue provided patient is in remission for 6 to 12 months. Steroids should be discontinued first. This is a very important issue. Risk of flare is in about half of patients after stopping the treatment. Chance of remission with restarting treatment is high. This practice should be individualized and should not be applied to all patients. Early and aggressive therapy, serology, smoking, duration of treatment, duration of remission are important factors, and of course we need further evidence for that practice. And thank you very much.